buttocks. There you go. That's okay. Can you bring the camera up? Yeah. Yep. Great. Perfect. That's great. So, you palpate the spinous process in the interspinous space. You can assess to see if there's additional separation between the interspinous segments and compare that to one another. So my index finger is palpating between, say, C7 and T1 there. And I get a feel for that interspinous space just in a static position. And then I compare that to the next interspinous space. Okay? And if you feel, say, at T1, 2, that space is wider between T1 and 2 than it is between C7 and T1, what do we think is going on at T1, 2? Is the segment more flexed or extended? If the spinous processes are further apart? More flexed. So it could be that T1, 2, T1 is more flexed on T2, okay? Or it could mean that T2 is more extended on T3. So you feel down at T2, 3, and that space feels normal. So we know that T1 is flexed on T2. Does that make sense? Okay. So that's one way just to sort of feel distances. Now, that's not a very reliable way to do it because it's a static position and spinous processes can do a lot of funky things. They can come out and curve to one side and look like a rotation, or they can actually angle down more on one than the other. So just looking at a static position isn't enough. Then you want to look at the mobility between those two. Okay? So to check the passive mobility, you can put your finger on the interspinous space and grab the head and just flex them down into more flexion and get a feel what happens to that spinous process. So I'm palpating the interspinous space. C7 is on the radial side of my index finger, and T1 is on the ulnar side of my index finger. And then I feel that separation. And right there, I'm feeling it separate, a little flexion. I can then bring the head back. And you want to watch so you're not compressing. And you go into extension, and you see if it extends. And she doesn't extend well at C7, T1, but she flexes a little bit better. So she might have an extension problem at C7, T1. And then I just travel down the spine. If you want, you can put your middle finger down at the next segment and then feel that motion. Okay? So that's flexion and extension. All right? You can get down to about T2, T3, and then you're just using too much neck in order to get to that area. So PA glide would be better like we did earlier from T3 on down. Okay? But we didn't really mention what you do for assessing the mobility in the upper thoracic area. And we mentioned the other day that that's kind of hard to treat anyway because of the angle and the curve. And you saw how it was difficult to get the towel to do the thoracic manipes up there so high. So this is one way to check that. You can also check side bending by just bending the head to the left and feeling the spinous process approximate toward the side you're bending, or the other side gapping away from the side you're bending. Okay? And then the last one is rotation. So you can rotate. Move the head. You'll feel the spinous process on the upper segment swing away from the direction of rotation, right? Because as you rotate right, the spinous process is going to swing to the left. So what I like to do is place my fingers lateral to the spinous process and feel it move away from me. You can do it on the other side, feel it move towards you. Okay? Does that all make sense? You're just getting a general relative motion between the segments when you do passive motion. You can also have them actively do it, and you just sort of pinch with your thumbs. I really like this because it turns into a treatment technique. So I'll take the, my left thumb is going to be on her left side, rule of the lower thumb. Okay. My right thumb is going to be on the right side of the segment above. So say I'm at T1, T2. I'm going to have her slowly rotate to the right, and I'm going to watch and feel my thumb move away from me to the left. She's stiff. She doesn't move much. You can see my thumb, sorry, go ahead and rotate. Those thumbs do not approximate very much. Okay, now move to the left. She does rotate a little bit better to the left. Watch my thumb again, right there, it starts to swing away. Okay, go to the right. My thumbs aren't approximating much more. Go to the left. She rotates better, going to the left. So she has a restriction at T1, 2 in right rotation. And then I could do a manipulation to improve that. Now one way is, since I'm right here, a little mobilization with movement. I maintain my thumbs, but I add a little pressure. It's a little uncomfortable. Turn to the right, and I push my thumb, my right thumb, on the spinous process, pushing it and encouraging it to go the spinous process to the left, which would be rotation right of T1, 2. And you do 2 or 3 of those.
You move your shoulder.
And you'll see my thumbnails will approximate a little bit, but she's really stiff. Do you feel that right there?
Yeah, I have a lot of upper thoracic.
All right, now you can go down to the next level and check. Go ahead and rotate, right? She rotates better at T2, 3. Okay, again. My thumb swings a lot better. The T1, 2 is pretty stiff in right rotation. Okay? So that's a lot of stuff. We went through flexion, extension, side bending, and rotation. Okay? Inner spinous, space palpation with those. And then we did rotation with assessing the motion with our thumbs on either side of the spinous process. Yes, Dr. Long?
I'm going to emphasize how to line the head up with the thoracic kyphosis just to make sure they're in connection mid-cervical lordosis so they can actually get to that thoracic region. You did it automatically, but you didn't say you did it.
So in this position, she's in a lot of cervical extension. So you need to bring her down into some flexion in order to start recruiting motion at that level. If you're doing it from here and just nodding, you're not going to get motion. You have to flex the cervical spine down and then palpate. Is that what you were talking about?
Yeah, so you
Okay.
just line the head up with the upper thoracic kyphosis. If somebody's really hypermobile in that mid-cervical region and you don't line the head up, bring them into a little bit of flexion, sometimes they'll just stay in that extension and they won't recruit any further down. You'll think, man, this upper thoracic area has no movement. And it's just because it's all recruited because of the position of the neck. So
So let's practice those.